Hi everyone, I'm Lauren Kennedy and my group had primary care as our environment of practice. Primary care is the provision of integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with clients, and practicing in the context of the family and community. Occupational therapy is included in the realm of primary healthcare, but not primary care. So, although primary care and primary healthcare are sometimes used interchangeably, they are different concepts. Primary healthcare is the broader term that takes into account other determinants of health, is more interdisciplinary, and is based more so on a social model of health. Primary care most often takes place in an outpatient setting, such as a doctor's office. And primary care clinicians serve a range of patients, which includes pediatrics, families, adults, and geriatrics. In the continuum of care, primary care falls within pre-acute care, as it is mainly focused on providing basic health care. Primary care covers a range of health services, such as prevention, wellness, and treatment for common illnesses. Primary care practitioners can refer patients to specialists, therefore, it serves as the entry point to the entire healthcare system that includes secondary and tertiary care. So, primary care services are moving toward a more interprofessional team-based delivery model since the passage of the Patient Protection and Affordable Care Act of 2010, which expanded the definition of primary care and included the goal of using interprofessional teams. Therefore, a more integrated delivery service is being used to provide a coordinated continuum of care through a collaborative healthcare network. The actual delivery of services can be done in an office, such as a doctor's office, or a community-based health center for in-person visits. It can also be delivered through a combination of in-person and virtual visits, phone calls, or emails, and now it can be offered via telemedicine. So with the push to evolve primary care to primary health care, services are being marketed to consumers through social marketing. Social marketing is the application of marketing to the solution of social and health problems. It's designed to influence the voluntary behavior of target audiences to improve their personal welfare and societies. So in this case, health institutions are marketing primary care services as a form of personal and social accountability, whereby you are increasing your own health and well-being, and in turn creating a healthier and more empowered community and world.
So when dealing with supervision and how OT practitioners in primary care facilitate their services, we have some communication frameworks that we found. Some receiving referrals from general practitioner for services is one of the main ways in which occupational therapists are able to service clients within the primary care setting. However, there are studies that show that OTs being able to refer their own clients and assess their own clients increases the ability for OTs to be able to have a more larger scope of practice in order to meet more client needs due to the lack of education that a lot of general practitioners lack when it comes to the profession of occupational therapy, which then leads into our other communication framework that is seen often. OTs in primary care often have to educate the interprofessional team on what the value of OT is, especially when it comes to OT evaluations and assessment measures, because occupational therapists within primary care often need to structure their assessments and evaluation practices for not only the needs of the occupational therapy practice, but for all of the interprofessional teams within the primary care practice as well. And role negotiation is also a big component when it comes to communicating, especially within interdisciplinary practice in primary care. There are a lot of practitioners, whether it be the general practitioner, nurses, speech language pathologists, physical therapists, and sometimes social workers, and our scopes of practice can sometimes intersect with each other. So when it comes to working in a primary care setting, especially one that is interdisciplinary, occupational therapists often have to work and communicate with their teams in order to figure out who is going to give the best care for the client based off of their practices and their strengths. So some of the challenges that we see within occupational therapy working within primary care is the general public's lack of knowledge of OT. This limits occupational therapists from being able to work with many clients due to some lack of trust whether it be from general practitioners or from patients themselves, because they question their need for occupational therapy, which makes it even more important for occupational therapists to be able to advocate for the importance of our practice. In some cases, it's also found that there are unrealistic caseloads due to high number of referrals because occupational therapists are not widely in the primary care spectrum just yet. It's common that only one occupational therapist would be on staff, and the caseload, the amount of clients that is often seen in primary care settings definitely outweighs the amount of occupational therapists that are actually on staff, which increases the amount of workload that an occupational therapist would need to do at the setting. There's also a lack of diversity in the scope of practice that can be found. And this is due to the limited abilities that OTs have found within primary care in relation to having to educate the interprofessional team on the value of OT. General practitioners often have a very narrow idea of what occupational therapy is. Thus, whenever a general practitioner is to refer a client to an OT, is for a very specific reason that's limiting the ability for the OT to fully practice their strengths. And also, there is still a lack of research on cost effectiveness. So unfortunately, the reason why we see that there are not many occupational therapists within primary care just yet is because there's not a lot of research that is able to give evidence-based practice as to why occupational therapy is so important when in terms of reducing the cost of healthcare and reducing the amount of money that primary care facilities spend on their clients.
So the primary professionals in the discipline that are staffed are medical doctors and doctors of osteopathic medicine. So these are the generalists that specialize in internal medicine, family practice, or pediatrics. Obstetrician and gynecologists are the doctors who specialize in women's health care, wellness, and prenatal care. There are nurse practitioners who can serve as primary care providers in family medicine, pediatrics, adult care, geriatrics, women's health, family planning, etc., and they can prescribe medicine. There are physician assistants who collaborate with the medical doctors and doctors of osteopathic medicine to provide a wide range of services. So the role of the OTR, CODA, OT aide, and manager is mainly for screenings and evaluations to determine needs, and this would include obtaining an occupational profile. This can also include pediatric development, mental health, medication management, and safety. They can also give preventative behavioral and physical health interventions, and also link occupational performance measures with standard health outcomes.
It's also noted in research that the role of an occupational therapist in primary care is not necessarily to treat the client and help to rehabilitate the client, but again, to just give screenings and evaluation to determine the need and then refer the client to the next best area of practice, whether that be inpatient care or outpatient care with another occupational therapist in that area of practice.
So productivity standards and expectations vary depending on the stakeholders. In studies focusing on productivity in primary care, productivity is typically not defined and instead reported as the practice's output. The most common concepts of output used were throughput focused, which is based on the number and types of patients seen, procedure focused, which is based on the number of individual healthcare services delivered, and revenue focused, which is based on financial earning. Relative value units, or RVU, are also used to address physician productivity in the primary care setting. RVUs define the value of a service or procedure based on the extent of physician work, resources, and expertise required to deliver the services. A study conducted in 2020 looking at the productivity, quality, and cost of care based on the various practice styles of 285 primary care providers concluded that the average primary care physician generates 4,598 RVUs when working a full-time schedule, which is about 3.572 RVUs per scheduled appointment hour. As for staffing patterns, many primary care settings use a traditional staffing model. There was a study conducted in 2014 describing staffing patterns for 496 primary care practices. These practices were eligible for the study if they had mainly primary care clinicians, which included physicians, nurse practitioners, or physician assistants. Therefore, 100% of these practices staffed those members of the team. The study found that nearly all of the practices reported having administrative staff and medical assistants. However, among all of the practices, only 16% reported having non-traditional staff, such as pharmacists, social workers, community service coordinators, health educators, or nutritionists.
Occupational therapists also find themselves most commonly being staffed within that 16% of non-traditional healthcare providers. Thus, whenever we do see occupational therapists in the primary care setting, there's typically only one found, if any. And many OTs that are found in primary care settings currently are OT students fulfilling their capstone level work or professionals working in pilot grant funded programs. So we had the pleasure of interviewing Dr. Tracy Voss-Erlin, a staff member at Thomas Jefferson University, who previously worked in the geriatric primary care facility at Jefferson Hospital for 2 years. This position was a grant-funded position, which many occupational therapists end up utilizing when working in primary care. And this grant focused heavily on the interprofessional model. So our interviewee had the opportunity to work not only with the traditional providers of the general practitioner or the nurse practitioner, but also working with social workers and physical therapists and a pharmacist. Primarily, her population was of geriatric clients, older adults, and her program focused mainly on fall prevention. Primarily, her role was to take assessments to assess the client's needs and to provide them next best practice, whether that be a home health aide or an outpatient occupational therapist to be seen in order to work on rehabilitating and again, preventing falls. When asked how her role is defined, she often did role delineation and negotiation while she met with her team every morning. Many of the practitioners within her interdisciplinary team also had similar scopes of practice that in some ways can overlap with occupational therapy. So with every new client, there was a discussion with whether or not an OT should take on an assessment, or if the nurse should take an assessment, or if a physical therapist should take an assessment, and thus moving forward to work collaboratively as a team to best serve the client. When we asked what her unique roles were, she often would ask what's missing and how can occupational therapy fill this gap. And as an example, she gave that most general practitioners assess for cognition. However, as an occupational therapist, she assesses for functional cognition. And she remembers many times where there would be clients who were very surprised to see that though they can function well based off of the assessment given by their primary care doctor, they find that their functional cognition is different. Sometimes it could be better, sometimes it could be worse. And some challenges, ethical practice, and legislation that was discussed during our interview. A big component was insurance. Unfortunately, many individuals under her care, because they were of low socioeconomic status, sometimes struggled in order to pay for their primary care, especially when it comes to receiving OT practice. Another barrier was space. Working in a traditional primary care setting, there aren't many options for gyms or for recreational areas. So getting creative when it comes to the types of assessments or the types of interventions to do with a client becomes very important. And also role negotiation. As mentioned before, in her experience of working with an interdisciplinary team, sometimes scopes of practice can overlap, and the ability to step on the toes of other practitioners at times can come about, which then cause unnecessary conflict.
Okay, so to expand a little bit more on the funding and reimbursement processes that take place in primary care, we know that occupational therapy must have some sort of reimbursement agreement so that their services can be provided and that the OTs can be compensated for those services. And so that also has to be addressed in primary care. So there are different models of primary care. Sarah mentioned the interprofessional model, which Dr. Voss-Erlin used in primary care. So these primary care models exist based on different types of reimbursement, composition of service problems, and community or population needs. So the key is to know how to incorporate the right kind of reimbursement with the services provided so that financially OT can enter primary care which is what the slide is saying at the top there. The reimbursement model has to match the primary care service model that is being employed at whatever setting an OT might be working primary care in. So the reimbursement models listed on the slide are volume-based model, which refers to kind of a relative value unit or fee-for-service type of reimbursement. That's actually becoming less relevant in today's healthcare trajectory, just because it doesn't necessarily speak to the quality of the care provided, but rather just that the care itself was provided. So an example where fee-for-service care or reimbursement is used in primary care is in consultation. But then there's also value-based payments, or also known as alternative payment methods, which seek out high quality and cost-efficient care, which is focused on quality outcomes of interventions. And that's really what the payment is based off of. And so healthcare payment models are moving more in the direction of quality-based care and this value-based reimbursement than the volume-based reimbursement. So these value-based models were a result of the Medicare Access and CHIP Reauthorization Act, or MACRA, of 2015. And additionally, this model has a lot of support from CMS, or the Center for Medicare and Medicaid Services. So examples of value-based payment models in primary care are the Integrated Healthcare, or PCMH model, which I will talk about in a second. So the primary care models, which are listed on the right side of that screen, are interprofessional collaboration, which is something we've learned a lot about in our curriculum at Jefferson, as well as the integrated healthcare models, which the most common of that is patient-centered medical home models, or that PCMH that I mentioned already. And specifically, OT can play a really powerful role in that type of model because of its responsibilities in managing complex and chronic conditions through increased coordination and collaboration of care. Then there's also consultation, which I mentioned, and then community-based federally qualified healthcare centers, or FQHCs. And this is the Medicare, Medicaid, and private insurances, as well as other nonprofits that offer low or no cost primary care to medically underserved populations. And so again, just to reiterate, the reimbursement model type has to match the primary care service model so that OT can then begin to enter these primary care settings. And so the shift from volume-based to value-based care is actually a really big strength for OT in how it's looking for their occupational therapists to really emerge into primary care settings with a lot more strength. So as far as funding for these types of reimbursement, it differs per model. For the majority, the funding for reimbursement is based on the insurer's income for those who pay monthly or yearly for their health insurance. And then for other models like the FQHCs, Medicare, Medicaid, they're federally funded through the Health Resources and Services Administration Health Centers program. So just kind of in conclusion, all of this like funding and reimbursement information was really overwhelming to me and kind of difficult to understand, but the takeaways from it and implications for us as future OTs, I think, are really just to be aware of the payment models that will be existing in your future setting and kind of continuing to educate yourself about the nuances of them and being prepared to address reimbursement and regulatory issues, and then advocating for reimbursement, including the payment criteria and regulations, to really be able to understand just all the details of it and understand how different reimbursement models can promote things like OT moving into primary care. In terms of accreditation, the primary care setting is accredited by two major bodies of accreditation. And just to start, accreditation is meant to increase the quality and safety of a care setting by meeting standards set by a third-party organization, which provides a level of confidence to patients and users. So like I said, the primary care setting peers have two possible vessels for accreditation, one being the Joint Commission, which is something we've heard a lot about, and the other, the Accreditation Association for Ambulatory Healthcare. So both are those third-party organizations that provide accreditation to certain healthcare settings, including primary care. So to become accredited, organizations first need to be eligible based on criteria specified by the accrediting body. So not all accrediting bodies will accredit all settings. So they have to first meet the eligibility criteria. And then secondly, the organization must undergo a rigorous application process for which these organizations includes a survey application first, and then there's kind of an evaluation period where there's all of these different criteria that each of these commissions give to the settings. And then then there's like an approval or denial of accreditation. So for the Joint Commission, the application addresses things like community involvement and integration, access to care and continuity of services, assessment of needs, prevention and control of infections, patient and family education, medication management, governance and leadership, facility management and safety, staff qualifications and education, and management of information. So it's pretty thorough. And for the Joint Commission, accreditation usually can take up to 3 years. So it's quite a process. For the AAAHC, the application addresses things like quality of care, use of facilities, adherence to best practices, and management methodology. So then decisions are made based on these application processes, whether or not the setting can be approved or denied by these accrediting bodies. And then additionally, the settings could have or earn preliminary accreditation, accreditation with a follow-up survey, preliminary denial of accreditation, or just denial of accreditation.
So the healthcare reform specifically outlines 3 goals, which are improved patient experience, improved health in populations, and reduced per capita cost. With these goals in mind, the Patient Protection and Affordable Care Act was brought into law in 2010, which affects our OT's role in primary care at this point. This act made changes such as improved insurance for many, expansions in coverage such as within Medicaid and Medicare, the addition of wellness programs, supports to older adults, funding for mental health improvements, and specifically related to OT, the inclusion of rehabilitation and habilitation, mental health, and substance abuse benefits packages. In addition to these changes, also came groups such as accountable care organizations and medical home models. Accountable care organizations are teams which are responsible for quality and cost-effective care, and medical home models have a part in the coordination of a team for patients' continuum of care. Through these changes and groups, occupational therapy opportunities within primary care opened up. They were seen able to participate within accountable care organizations and medical home teams as they had opportunities for large contributions on these teams. Occupational therapies focus in client-centered care throughout the lifespan, prevention, wellness, and self-management focuses are able to play a role on these teams and work toward the goals of the healthcare reform. In addition of preventative and wellness measures in primary healthcare are the risk assessments and reviews of functions, which are now added in primary care. Other acts which impacted OT's role in primary care consisted of Protecting Access to Medicare Act of 2014, which has led to the ability for OTs to work alongside others on the team to address mental and behavioral health, and others such as the Comprehensive Addiction and Recovery Act of 2016 and the Support for Patient Communities Act of 2018, which both showed value in their role in pain management within the opioid crisis. It'll be expected that there will be more acts which represent OT's roles in the future, but as of right now, there are only a few. So in order to become part of the primary care, it is going to be essential that we establish clear roles within the setting and on these smaller healthcare teams, done so by advocacy. Our interprofessional teams need to understand where we play in the role in giving back to the team so that we can gain support from other professions in our role here. Some sources state that this is hard because we do not have enough clear evidence of our role here, so it will have to turn towards advocacy and awareness of our possible contributions and the evidence of international success, which has prospered in some areas with our inclusion. Occupational therapists will need to continue stating our roles and teams, such as the accountable care organizations, and the specific additions that we can make that are in line with the healthcare reform and alleviate primary care physician responsibilities. Specifically, our role in healthy aging and fall prevention and geriatrics, pain management among the many patients in primary care, screening in pediatrics, and self-management through the course of prevention to follow-up, all of which reduce costs, reduce liability risks, and improve patient care due to the help it provides by taking responsibility to these stressed out physicians. Specific other areas that we've been talked about advocating for are changing cost measurements to quality care measurements under the healthcare reform, and continued use of technology such as telehealth, which continues to open up possibilities for OT in this field. We need to bring awareness of our ability to treat the whole person from prevention to management, and that we are valuable to the primary care team, and that OT's services need to be accessible to all individuals. In order to make this all happen, we need to provide evidence of our contributions, such as through studies on OT effects in primary care models and other similar settings, advocacy on OT enhancing patient health, and our cost effectiveness. All would increase our credibility and the strength of our inclusion. However, we have had some current gains in advocacy, which are the removal of outpatient OT caps, which limited our services, and the inclusion of the definition of primary care and OT's role in the Accreditation Council of Education in 2018. This promotes OT in primary care, and the inclusion of educating future OTs in the role will be essential so that profession is ready for this continued advancement in the scope of practice. OTs have their own set of ethical guidelines, which we must abide by. Though not trying to make an effort to practice in primary care, we are going against the ethical principle of beneficence or the concern for others and the value of demonstrations of unselfish care. To solve this problem, we need to continue advocating our role in this field. Our values of justice and equality or the same rights and access to care to others, such as an OT. Without our foot in the door in primary care, this is difficult as not all patients are referred to us. Again, we need to advocate so that we can make sure to see that the patients need us the most. Like most healthcare settings, it is pretty common ethical concern to need to keep professional boundaries in both relationships as well as boundaries such as staying within our scope of care. This also goes with making sure we provide an understanding to others to avoid. There are also other professions that are coming into our roles, and we need to be aware of this. Our lines need to be clear. We must provide trained OTs to work in this setting to avoid harm of patients and provide them with the best care possible. So educating future OTs will be essential. It is healthcare professionals' duty to keep information confidential, and we are no exception. And we have a duty to provide evidence-based care, which may not be the case as we begin entering this field and are under supervision of other healthcare professions. It becomes sticky waters. Being aware of this, educating ourselves, and working better to find our role will help to avoid these issues. And for liability, although there's not a lot of information about liability issues commonly present with OTs in primary care due to its new involvement in this field, there are issues present in primary care that could be alleviated by OT's addition to this field. These issues consist of the burnout of physicians who are caring for many patients and have many responsibilities, diagnostic areas such as the diagnosis of developmental delays, which can be missed with the high-stress job, care transition mistakes, whereas clients leave facilities too early on information about patients and their functionality is not transferred successfully, causing accidents, other communication issues such as patients not being educated properly on medication or understanding resulting in medication claims and not adhering correctly to medication, and the lack of follow-up with individuals with concerns. OTs would have the unique ability to step in and take some of these responsibilities from physicians, which would in turn avoid these liability issues. However, liability issues concerning OTs in primary care field may be the fact that their scope of practice within the setting is poorly defined, so liability becomes riskier as they either provide care they are not considered competent for, or fear of this could impact the care of patients and result in patient injury or other liabilities issues related to ethics.
Some topics that are right for program development in this setting are the scope of practice for OT and how to reimburse for OT services within this setting. Occupational therapy does not just have to treat clients once an issue arises. Practitioners can play a role in the health and wellness, education, and intervention, and lifestyle redesign to focus on a preventative approach to healthcare. This profession strives to help individuals participate and engage in daily activities they need and want to do. So being able to have an OT program within the primary care setting can allow for professional guidance for lifestyle modification and development of healthy habits early on that could prevent patients from having a significant medical or emotional event that could impact their functioning in daily life. Research from July 2014 on the expert panel on effective ways of investing in health had a definition of primary care that they published. It reads as follows. The expert panel considers that primary care is the provision of universally accessible, integrated, person-centered, comprehensive health and community services provided by a team of professionals accountable for addressing a large majority of personal health needs. The professionals active in this primary care team include, among others, dentists, dietitians, general practitioners, family physicians, midwives, nurse, occupational therapists, optometrists, pharmacists, physiotherapists, psychologists, and social workers. OTs can have programs developed for this setting to have interventions that address physical health, mental health, and contextual barriers to occupational engagement that may be more accessible in this primary care setting to reach a wide range of clients. OTs can provide services that extend the ability of physicians, nurse practitioners, and physician assistants to provide holistic care. We can focus on how symptoms affect their functioning. We can improve patient satisfaction, provide simple interventions that can be done at home or with limited supervision before referral. We can also improve participation in occupations through activity modification or adaptive equipment and techniques. We can even provide group education or intervention sessions to address prevalent issues among this population, which could include medical management, sleep habits, and healthy diet patterns. Specifically, programs can be centered around self-management for chronic conditions, self-management for psychiatric conditions, fall prevention, driving and community mobility resources for older adults, behavior health approaches to cope with life stressors, and redesign of the physical environment. It's crucial to spend healthcare dollars in the most beneficial way to ensure individual and population health. OT is limited by what they can be reimbursed for in the outdated fee-for-service model. However, we can provide patient-centered and comprehensive intervention plans if our services are embedded in a bundle payment to help ensure quality and coordination of care. As long as we can let people know how cost-effective our services are, people will see the benefits of OT intervention. Focusing on the scope of practice and what OTs are trained and skilled to provide services in primary care, we must have interprofessional awareness. We must take an educator role to educate the interprofessional team about how our practice aligns with the primary care values of providing care that is person-centered, comprehensive, integrated within the continuum of care, and involves patients, families, and communities. Our roles within the primary care setting can be an asset to the interdisciplinary team by coordinating care with the appropriate health professionals to ensure efficient but quality care. OTs can provide screenings and assessments before the patients have to see the physician, such as screening children at risk for developmental delays, then linking families with support services, resources, and the proper community-based care for conditions such as developmental delays, autism, and socio-emotional delays. Then OTs can communicate their findings with the rest of the primary care team to determine who will provide the interventions needed. This team approach can improve the efficiency of the entire practice, allowing more patients to be placed in rooms and assessed than could be done if only the physician did a majority of the clinical assessment. This distribution of assessment responsibilities can improve patients' experiences at the physician's office, as there would be fewer patients waiting for extended times in the waiting room. We must also take an advocator role to push for our profession to be recognized and respected as an approach to care that provides positive patient outcomes in this setting. To develop and strengthen the position of the profession in primary care, we need promotion and awareness of the benefits of OT to policymakers and the public at large. It's needed, as well as the evidence for the cost effectiveness of OT interventions and how without them, many patients may experience detrimental health outcomes. Hopefully, we will open the door into OT becoming more regular as a practice setting within the primary care field. Hopefully, we can provide client-centered and evidence-based care for all clients to promote overall health within this setting.
We'd love to hear any of your questions or comments about this presentation, so please let us know on the discussion board.
And these are just our sources, so thank you guys for watching our presentation.